Hello class, welcome to your medical imaging lecture. I'm Matt Guerin and I'll be going over the basics of some medical imaging, especially as it relates to surgical pathology. We have 6 cognitive objectives for this lecture, and 2 affective. Feel free to look those over and let me know if you have any questions. So organizing this lecture, we're going to go over the history and principle mechanics behind radiology. We'll talk a little bit about the different types of imaging that you'll see. We'll also talk about how radiology and pathology coexist together, and then specifically focus on surgical pathology. And then finally we'll end with safety, which is ultimately the most important thing so we don't mutate. So let's look at the initial discovery of radiology. And we say discovery because radiology wasn't actually invented. It was something that existed since the dawn of time. Particles have always been giving off radiation since the birth of the universe. But this gentleman by the name of Wilhelm Conrad Röntgen actually discovered the use of radiology back in 1895 and utilizing X-rays for the first time. As any good scientist, what he did is he stuck his wife's hand in this box and took the picture that you see here. Her response was quoted as saying, "I have seen my own death." It wasn't long after the discovery of X-rays that they started being used in a clinical setting, and we first see this happening in Birmingham, England. Additionally, in that same year, we see them used as cancer therapy in Chicago. And not too far along after that, X-rays are very dangerous, and it was a while before we had proper safety precautions, and the man by the name of Clarence Daly has the privilege of being the first to die from X-rays while working on bulbs with Thomas Edison. Some have a very poor opinion on Edison, and this might not help overall. Now, X-rays work by a very simple process. We have a machine that generates the radiation, and it's targeted at an individual or an object. And what happens is the radiation tries to pass through that object. Things that are more dense and able to absorb the radiation a lot better tend to appear as white, and the case here in the demonstration is bone, whereas things that are lighter and less dense, like air and tissue, appear darker in X-rays. Now, this is the basic premise of X-rays in general, but we see things with like CT scans and MRIs that work a little bit more complex than that. But the ultimate goal is to have a device on the opposite end there, where the hand is placed, that is going to collect this radiation and interpret that data of what passes through and what doesn't, and that's going to create ourselves an image. When working with radiation, we don't want to end up like Clarence Daly and succumb to death, so we have to make sure we're properly aware of what types of radiation exist. When we're dealing with non-ionizing radiation, this is low energy. This is stuff like we see in the microwave or things from our TV remotes. They do give off radiation. It's very low frequency. It has an inability to interact with our tissue. And this is relatively safe. Cell phones give off non-ionizing radiation too, so that's why there's no real link between cell phone use and cancer. Now, I say a minimal risk because technically things like microwaves can cause burns. Burns can ultimately lead to things like mutations, which can ultimately lead to cancer. So it's not purely safe, but it's mostly safe. Now we compare that to ionizing radiation, and ionizing radiation is very short wavelength, high energy, high frequency wavelengths. And what this does is it actually starts breaking down tissue as it hits. When that happens, the tissue attempts to repair, and so if we're talking about human tissue, that ultimately leads to damage, and damage can have cascade effects, which can ultimately kill other tissues, and additionally that can lead to things like cancers, because mutations tend to occur when the tissue tries to repair itself. So this takes the extreme ends of the radiation scale, looking at some of the higher frequency UV rays and gamma radiation, sort of the stuff that you see with the Incredible Hulk there, getting blasted with that. But this is the stuff you want to avoid. So here's a nice little table where you can kind of see the difference between the two. Unfortunately, visible light falls into the non-ionizing category, otherwise that'd be very dangerous for us. But UV light kind of straddles both, so that's why there's some UV light that ultimately is relatively safe, and some sun blocking stuff will basically take care of that. But on the extreme end, it's partially ionizing as well, so it's important to not dilly-dally too long in the sun while trying to get your tanning lines there. You can actually see tanning booths show up on the scale too, as sort of that teeter-totter point between non-ionizing and ionizing radiation. So let's go ahead now and take a look at various diagnostic imaging here, and then the different types of radiology that you'll see in a clinical setting. So first we'll talk about diagnostic imaging, and we kind of talked about this in anatomy as well. So there's the 5 main types: sonography, radiology, tomography, and MRIs in nuclear medicine. Then there's interventional radiology, radiation therapy, and forensic radiology. So let's start by looking at sonography. Sonography is the most non-invasive because it uses sound waves, which are non-ionizing. It's technically not even radiation, but it's classified as transmitting signals. So sending the sound waves doesn't impact the tissue. It's safe for the patient, but it doesn't really give us any sort of contrast with soft tissue. It's really good at identifying cystic structures. So if you have a tumor that's a cyst, sometimes ovarian tumors are good for this. It's classically used in childbearing. So if you think about the amniotic sac filled with fluid, we can see the contrast between solid versus the cystic amniotic sac there. But other than that, it doesn't really show us too much. But it's cheap, it's highly mobile, but you can do these pretty easily and inexpensively, and it's kind of a nice initial workup for certain diagnoses. Here you can see a hypoechoic lesion here, so that means it's showing up lighter than the surrounding tissue. So obviously there might be some cystic structure there, or maybe necrosis that you can potentially see where the solidity of the object is not as maintained as the surrounding tissue. We can also use sonography while talking about things like blood flow. So using a Doppler ultrasound, what we'll do is measure the speed of the blood as it transmits through vessels. Now, this color here is an added artifact, and it's not what comes from the sonography itself. But what happens is the computer will actually interpret the speed on how fast something moves through the sound waves, and that'll transmit it to the color here. So we want to see things being orange and red, meaning they're flowing at a normal pace. Things that are slowing down are showing up in like a bluish to a sort of darker color here. So it's important that you kind of be aware of the color contrast, but know that it's not a result of the instrument itself. Now this is useful for detecting things like stenosis in the blood vessel or aneurysms. So aneurysms would see bulging of the vessel here. So what you can tell is this has some sort of narrowing in this region that is causing a significant flow of blood to slow down. You see a little bit up here as well, so we wanted to see that nice consistent flow. So that's good for things like angioplasties if we need to go in and put stents in a patient as well. Now, general radiography is something we've probably all done or had done on ourselves in the past. Now, this uses ionizing radiation, and you'll know when you get an x-ray that the technician likes to stand behind their little protective shield, and we'll make sure that anything that doesn't need to be radiographed will be covered up with a lead apron. Well, these are nice because they can give us a quick snapshot of what's going on in the body, and they're really quick, really inexpensive overall. Overall x-rays shouldn't cost you too much. So things like broken bones are a common occurrence for testing radiographs. So you can see if the bone's broken, you can see if there's any sort of shift, but we don't get to see any sort of soft tissue elements there. Chest x-rays are good because actually the absence of structures, namely the lungs, will provide some insight, right? So the lungs are filled with air, which usually show up as nice dark areas in these x-rays. And so you can kind of see that if you look in the image behind me here. I've got a chest x-ray, so this is actually from a COVID patient, so it's got a little bit of scarring tissue, but it should come across as very clear. And so that's actually useful information, because if it's not clear, then we know something is wrong. So some of the cons of this is radiation exposure, and obviously we don't get a lot of information from this. This is considered an invasive technique, and a lot of times we have to use contrast medium, which is also slightly radioactive as well. We can use these tools to be a little diagnostic, so we can determine things, especially with tumors, if the tumor is osteolytic, meaning that the bone is being broken down here, so you can see the hollowing out. So again, that's a hypoechoic area, well, not echoic, radiograph region, and then you can see a radiodense area with an osteoblastic lesion, where it's actually building up bone and creating more dense areas for the radiation to be stopped by. And again, if we use the contrast medium, like I mentioned earlier, now usually it's some sort of radioactive element that's going to be picked up, but it allows us to take an x-ray and see stuff that you probably couldn't see. Normally things like blood would be liquid, allow the radiation to be transferred through, but when they put these dense contrasts in, we can actually see what's going on. So this looks like it could potentially be a burst aneurysm. They can do these for a lot of angiographs. We saw that with the ultrasound. You can do these with the angiograms as well with x-rays, and see if there's any sort of blockage. And going back to that too, you can actually sometimes see narrowing in these areas as well. So it looks like maybe there's a lower flow here, or blood being kind of stopped. So they do have their purpose for clinical practice as well. Now, taking the x-ray or the basic radiograph, we can actually make 3D models for that. So now when we do that, we can refer to that as a computed tomography. This is again using ionizing radiation, so it is an invasive procedure, but it's a relatively quick, it's fairly inexpensive, I would say, compared to an MRI, but it's a relatively expensive thing. But the advantage here is we're taking multiple x-rays, we're taking multiple and sections and angles of the patient, and now we can get a better picture. So this will actually, because of the continued use of x-rays, allow us to continually build up an idea of what's going on in the patient, and we can start to see soft tissue a little better. So it's not going to be as good as an MRI, but it's still something better than just a basic x-ray. So we still might have to use a contrast medium, especially for things like blood vessels, but at the end of the day, we'll be able to get nice little cross sections here, and you can kind of see what's going on. So in the one on the right here, we see, again, our lungs, nice little empty spaces of air that should be periodically punctated with these little vessels and stuff, the bronchi. But look over here. This is usually, we're looking at the breast here. It should be normally fatty. Instead, we see this nice solid fibrotic lesion. Could be some dense fibrous tissue, or it could be a mass. So we definitely see some clarity there, where we wouldn't have seen that on a basic x-ray. Here in the cross-section of a CT scan, and remember, we're looking at the patient basically from their feet. We're going up. We can actually see some sort of lesion here that they're pointing out in the soft tissue. If you think about this cross-section and where we're actually looking, again, we have that black space. This is likely, or not likely, this is actually in the chest cavity here. So we see this is the same image with the lesion in a transverse section. Next, we have magnetic resonance imaging, or the MRI, and this one is really great for visualizing soft tissue. It's really bad at doing bone, though, so we can't get the best of both worlds, unfortunately, with any of these imaging modalities. So you kind of have to decide what you're looking for and then proceed from there. But if you need to see something with soft tissue, particularly any sort of nervous system, brain disorders and brain lesions tend to be highly visible with an MRI image. These are the way to go. Now, these tend to be a little more expensive for the patient. They also have a longer scan time, so patients that are claustrophobic may have difficulty with these, although they do have the sort of, it's called a open space, I believe, MRI, where patients can actually have an MRI done without having that claustrophobic feel. But additionally, patients with implants, metallic implants, will have difficulty with these procedures because rather than using ionizing radiation, this uses magnets. So a magnetic field, and if you recall from anatomy, basically it measures the lining up and then the dissipation of the magnetic fields of the hydrogen atoms in our body. And by measuring that, we can decide what the soft tissue components we're looking at. So they do have mobile ones of these as well, although the ones we classically see are the big open spaces, where you just sort of scan someone in or slide them in like a little tube. But again, it's non-invasive, which is kind of nice. So if you can get yourself in a full body scan and see all the soft tissue, absolutely great. Here we have a nice coronal section of an individual. You can see all the soft tissue components. Lungs still have difficulty showing up. They're always going to be kind of a trouble spot. But based off the different scans, we can see the musculature, we can see a little bit of where the bone should be, but notice bones doesn't really come up as well. And we see a really good presentation of the brain here. We got our liver, we got our kidneys, things like that. So MRIs are really good if we're looking for soft tissue, tumors, and any sort of disease in that regard. Because these are really good for CNS, you'll see these used for a lot of neurosurgeries. So here we have some brain lesions. These look like metastasis here. You can see little hot spots. They actually can use fMRIs, or functional magnetic resonant imaging, And that's where they see what areas highlight under certain conditions. So you might have heard of little studies where patients are shown images, or they do these psychology studies of different drugs, and they can see what areas of the brains are impacted based on how they light up. And what that's doing is just measuring activity in those regions as well. So MRI is definitely a useful tool, and it's something I always thought it would be kind of cool, is just get your own MRI and CT scan and have just walk around with your own personal picture of your body inside and out. Okay, so finally, nuclear medicine. This one is the most specific of all the modalities, and it's really only functional for determining the physiological or function of an organ or structure. And particularly with tumors, we use this a lot for determining metastasis, or whether there's a hyperactive tumor. So some tumors can be functional, and if that's the case, when they are functioning, we can pick that up by using radioisotopes. Now, the classic example of this is thyroid tumors, which we'll see in this image here. You can see the thyroid is lighting up with these radioisotopes. So the patient will be injected with radioactive iodine, and anywhere the thyroid is picking that up will highlight on our positron emission tomography, or our PET scan here. But a classic way to use this is determining metastasis. So if we want to see where that thyroid tumor, or any other tumors that are particularly highly active, so you can look at tumors being rapidly growing, they're going to absorb a lot of nutrients. So if we inject the patient with some radioactive isotopes for things like sugars, they can pick those up as well and see oh yeah, you've got some really hot spots over here in the lung, and maybe some in the brain, which means there's probably some really aggressive activity going on there. These are not portable. They are also invasive, because now you're exposing the patient to not only the imaging, but we're injecting isotopes in them as well. Now, the isotopes have a short half-life, and they usually just flush out, so it's not overtly negative, but it is an invasive procedure nonetheless. So again, this is something that you've already kind of determined your diagnosis, and you're going to follow up and determine basically a staging or a clinical stage particularly. So now let's move on to interventional radiology. And this is something that you'll hear often in the clinical setting, and when you go off to clinicals, they'll talk about specimens coming from IR, or interventional radiology. So if you're not familiar with the term, or it's something you haven't worked with before, that's what they're talking about when they say IR. And what this is, it used to be its own kind of subspecialty, but it's now really something that radiologists can actually specialize into, because it's got a little more nuance than just simply using imaging to do a procedure, which is ultimately kind of what they're doing. But what we do here is we use things like ultrasound, CT scans, and MRIs in conjunction with a procedure, or getting a biopsy or surgical treatment, in order to get a more precise or accurate result. And what we see is there's something called stereotactic procedures, which is creating a map three-dimensionally during the process, and it requires two planes, so you can get an x-axis and a z-axis like that, or x and y as well, and basically try to narrow in and create a 3D localized image of what you're working on, and then try to pinpoint where you need to take a biopsy, where you're trying to place your instrument or device, particularly for stent placement. But you'll get a lot of breast biopsies that are done using ultrasound or CT scans, and then a lot of brain biopsies are done using MRI. So first up is the needle core biopsy using an ultrasound. So what you can see here in the image is the ultrasound is kind of showing you where the needle is, and so you can kind of determine whether or not you are in the tissue that you need to be in, or if you need to get a fine needle aspiration. Sometimes for thyroid lesions or cystic structures, they can go and try to get some of the fluid or cell types out of those regions, and what they'll do is they just try to triangulate using the ultrasound and the needle to make sure they're exactly where they need to be. So you see this being done on a kidney over here, you see it being done on breast, but it's nice because this is an outpatient procedure. This is something a patient can go in, schedule, get done, and then come home the same day. Here's a couple of examples of how those biopsies kind of turn out. So you'll get a lot of breast core biopsies, and they'll usually say things like stereotactic or ultrasound guided biopsy, and then you just kind of indicate that in your report as well. But when they do these needle biopsies or needle core biopsies, that's what they're doing, and they're often done in interventional radiology. I have heard of some sites where pathocysts will actually do these as well, or at least assist in them, because sometimes they'll want to do a frozen section to make sure they got the viable tissue out at the time, or in analysis, and we'll talk about kidney biopsies much later, but you can see the tissue, make sure you're getting a proper glomeruli and the cortex and medulla contents in there to make sure you're getting what you need to make a proper diagnosis. So let's go ahead and take a look at a quick ultrasound guided procedure so you can get an idea of what that's going to look like.
Ultrasound guided biopsy of the liver or kidney can be performed as an outpatient. Normally the patient will require a 4 to 6 hour recovery time, but this can be performed as an outpatient with some moderate sedation. Ultrasound guided biopsy of the liver or kidney can be performed for either medical conditions or can be performed for masses or tumors which are seen on other imaging studies. This can be done in a convenient outpatient setting without the patient having to go into the hospital, and the results will go to the referring physician within several days.
See, wasn't that nice? So let's move on to CT guided procedures, or fluoroscopy. So this is where we use a continuous X-ray to see what's going on, and this is often used for orthopedic surgeries, especially with hardware placements like you can see on the bottom here. You can also see nice little images when they're doing things like colonic or urological resections, that they make sure that they can properly identify where those particular organs are. The most common thing they'll use is a barium contrast that they'll have the patient ingest, or that they can inject, so that they can properly see the soft tissue. Like I said before, CTs still require that contrast medium to be used in order to visualize soft tissues, or particular soft tissue, most likely the empty spaces like colons and vessels, to see those effectively. But what you'll see here is basically the patient can get continuously scanned to make sure that the tools are creating that 3D map and proper placement or resection can be done. Biopsies can be done as well. You'll see these with breast-guided biopsies on top of the orthopedic surgeries and the urological surgeries. And then magnetic resonance imaging. These are typically used for neurosurgery. So they actually have mobile MRIs that they can wheel in, or at least have nearby, that the patient can be mapped with. And because the brain, we don't want to just go in and take large resections. We usually, with particularly tumors and even biopsies for the brain, which are relatively uncommon but sometimes necessary, you want to make sure you're as minimally invasive as possible, and this is what ultimately helps do that. The nice thing is you don't have the radiation risk, which is great when you're working with the brain, because you don't really want to be subjecting your brain to radiation. So you'll often see these with tumors of the brain. They'll come down as interventional radiology, MRI guided resections. So let's go ahead and take a look at another video. This one's a little more not for the faint of heart, I guess I'll say.
This is a video of a stereotactic biopsy on a patient with an intracranial lesion. Prior to the biopsy, the patient has had a CT scan with a stereotactic frame attached to her cranium. Coordinates for the biopsy path are then calculated. This is done by fusing the CT and MR images on a computer. The lesion is localized relative to the frame, and exact coordinates are calculated in 3 dimensions. These coordinates are set on the stereotactic frame, and the needle is calibrated. The frame is attached to the patient, and the point of entry is marked on the skin. Local anesthesia is administered to the biopsy area. A vertical skin incision is made with a scalpel, and the point of entry is marked on the cranium. A small hole is drilled in the cranium. The duramater is opened with a cross-shaped incision. The biopsy needle is inserted through the hole in the cranium and into the lesion. The needle is rotated while aspirating with a syringe. Several biopsies are taken from different depths. The biopsies are placed in formalin. 2 more biopsies are taken for cryosectioning. Finally, the wound is cleansed and closed in 2 layers.
Pretty freaking cool, isn't it? So we've just been looking at how radiation is used in a helpful setting, namely to diagnose tumors and help us with surgical procedures. But radiation is a very lethal thing, so it only makes sense that we find a way to use it for its lethal potential. And that's where radiation therapy comes in. Ultimately, radiation is going to be used to kill tumor cells. Now, tumor cells tend to be really prone to radiation effects. Namely because they grow really fast, and when you're rapidly dividing, your DNA is susceptible to mutations and being disrupted, and that's where the radiation therapy works. So what this will do is ultimately target a particular area or where the tumor is. You don't want to just mass dose somebody with radiation and hit them with high doses so that ultimately the tumor cells will die. Now, this can be used in conjunction with things like surgery and with chemotherapy as well, and certain tumors may be receptive to radiation and some may not. Terms associated with radiation therapy include postoperative therapy, which, as the name implies, occurs after the operation. So you remove the tumor, and in that case you want to blast the patient in the particular region the tumor was to hopefully kill off any remaining tumor cells. But the other one you might not be familiar with is neoadjuvant therapy. And so you'll get specimens that'll say neoadjuvant breast tumor or lumpectomy. And what that means is that the tumor was treated with radiation prior to resecting. And so what they'll do is they'll zap the tumor and try to kill off as much as they can. It might even shrink the tumor a little bit. But it's important to note, especially in a dictation or in the history, because what we'll see is the tumor cells are going to be necrotic or fibrotic. So oftentimes pathologists will want to measure tumor or treatment effect with those neoadjuvant cases, and so you might have to submit a little bit more tissue, and then they can determine the degree of tumor tissues that have been killed off by the radiation. So neoadjuvant is a very common thing we'll work with in surgical pathology. And finally, let's talk about forensic radiology. Now, this is also tied into autopsy radiology, and we'll talk about that a little bit more when we get into autopsy pathology in spring quarter. But this is something that you may or may not see depending on where your autopsy locales are, or what your hospitals do, especially when using imaging devices for autopsies in a hospital setting. A lot of times hospitals don't want to have the patients or the instruments they use for live patients kind of in the cadaver or the morgue area. It just has that like negative connotation to it. But particularly when we're dealing with autopsies, that's nice because you can use a CT image or an MRI if you can't get consent, or if you're wanting to do a virtual autopsy because maybe the patient has religious objection, or they want to have a body intact, or you still want to find out something. And so these can be another way to do that while getting the patient a little more on board. And they've done some studies where these virtual autopsies are not as great for determining cause of death, but used in conjunction with even just a laparoscopic follow-up biopsy for autopsies can yield really good results and make some really good clinical correlates for autopsy and cause of death. But in forensics, you can use radiology to correlate the death. So sometimes all we have are things like dental records, or a particular a history of maybe device placements. So maybe they had a hardware in the shoulder or the leg, and so if you can't identify bodies, sometimes this is a way to do it, especially in mass casualty events when you just have bodies that are all over the place, and identification is very difficult, and things might be combined. Sometimes using things like radiographs could be in a way to identify some of these individuals after they're dead. So that wraps up medical imaging kind of as a whole. Now there's definitely a lot more to it, and you can definitely go down some rabbit holes with imaging used in the medical setting, but let's move on in its relationship to pathology. So oftentimes when we look at radiology and pathology, they're really trying to do the same thing. So both of them are trying to look at something. In radiology, it's these images from the body, and in pathology, it's specimens and tissue. And they're trying to come up with a diagnosis, and the diagnosis is ultimately going to help things like staging and treatment effects, and determine what the ultimate outcome for the patient is. So really, they're two professions that are trying to do a very similar thing with different tools, and it's kind of a neat way to think about it. So at the end of the day, some things work really well on radiology, and there's certain pathologies that can have very specific radiographs. You'll hear about things like Codman's triangle on bone tumors, and we'll talk about that in a little bit, and how maybe not as characteristic as some people might think, but things like scalloping. But however, radiographic images are not really a true way to diagnose something, in my opinion. I think it just kind of goes to say, and that's why ultimately tissue procurement is the gold standard, because you can't argue with what you see, right? If you have a tumor in front of you, if you look at the cells of that tumor, you know exactly what it is. But radiology is trying to get a little bit closer to that, and there's ultimately going to be if working together and used in conjunction, you can actually get confirmation of diagnosis and find out some more nuance, and maybe even more clinical approaches that might be better rather than straight up resections, depending on the tumor. Because there are some harmful effects with over-imaging, and we'll talk about those in a little bit. But for radiology itself, there's certain things, if you recall from anatomy, that a radiograph is pretty much going to guarantee you a diagnosis. So if we look at this image here, clearly we got a broken bone or cortical disruption, as you'll hear it called clinically. And you don't really need to biopsy that to identify what's going on with the patient. Additionally here, what do you think's going on here? Looks like we're in the abdomen area, so we got our intestines in this region. So looks like potentially either a kidney with a kidney stone in it, so you can clearly see things that have stones in them, right? So anything like gallbladder stones or kidney stones can easily show up on a radiograph, and any foreign objects in the body, like we see here. What do you think the diagnosis is here? Yeah, this is actually a case I had of a bottle in the patient's rectum. So things like that, radiographs are perfectly viable tools to give us a diagnosis and a plan of action. However, things like Codman's triangle, like I said, was a radiographic characteristic that we see, and what we notice is going on here, and you don't have to know the specifics per se yet. You'll talk about this much later in pathology. But a Codman's triangle is usually a result of the periosteum of the bone, the outer layer, basically being lifted up, and it creates this triangle here, right? And I know probably you're thinking, man, that doesn't look like much, but this is what they tie to Codman's triangle. So now classically, this has been a diagnostic principle, or sorry, a diagnostic feature associated with osteosarcomas. So usually you'll hear about osteosarcomas and they'll have a Codman's triangle, which is absolutely true, they do. However, you also see that in Ewing sarcomas, and in osteomyelitis, and in active aneurysm bone cysts, giant cell tumors, chondrosarcomas, metastasis. So you can see there's a wide range of devices or diagnosis that could be associated from just that one function there. So we can't just simply rely off the radiograph. We have to actually go in and biopsy to the tissue to see which one of these many diagnoses this particular occurrence can be. Here's another example. So we have one lesion. Let's say we're looking at a breast tumor. The mammogram, which is just an x-ray of the breast, says it's 1.9 by 1.0 by 0.8. The ultrasound measured it at 2.1 by 1.0 by 0.8 centimeters. And then they went and did a CT for their stereotactic biopsy, and they found that to be 1.8 by 0.9 by 0.6. And then you get the lumpectomy in your lab, and you measure it at 2.0 by 1.1 by 0.8 centimeters. Now, of all four of those different values, which one would you put your money on? Now, if you said the pathology findings, I'd go ahead and give you your money back. So ultimately, that's going to be the measurement that you have, and you can't argue with that unless you have poor measurement skills, that is the true value. Now, it doesn't seem like those values are off by much, but when we're looking at breast staging for tumors, 2.0 or 2 centimeters is actually a cutoff. So if the tumor is greater than 2 centimeters, that means it's going to be upstaged. If it's lower than that, it's going to be a lower stage. And staging impacts a patient's treatment. So accurate measurements are very important, but it's something that radiology is trying to do because we at least want to know, okay, we have a almost 2 centimeter tumor. That's going to help us know what course of action to take for the patient. So rather than looking at them as two separate professions, it's better to look at them as being a conjunction. And a lot of radiology and pathology are actually looking at subspecialties where they can kind of, you can basically be a radiologist, pathologist type thing. And so what you'll see, and you'll do this a lot with your specimens in the second year, is you're going to be looking at radiographs from the electronic medical records or in the LIS. And so patients will come in, and breast tumors tend to be the most common use for these types of devices. But you'll pull up the imaging and you'll try to correlate and find where your tumor might be in the specimen you have, as well as identifying where biopsies were taken and making sure that you accurately submit the biopsy site. And we'll talk about those in a little bit, but you can start to correlate things like that using the medical records from the patient. There's also something known as RadPath conferences, and this will do a mock demonstration of in lab for this week. And what this is taking the radiographic findings and correlating them to the pathological findings and trying to come up with diagnosis and ideal treatment effects and things like that. So like I said, with things like neoadjuvant, and we can kind of see what how well the radiation did prior to use, and then measure that with the actual tumor. So here we've got some cystic structures that are going on here. A case of like the jelly belly, pseudomyxoma peritonei, and you can kind of see that on a radiograph, and it might show up as multiple images. But by correlating those images to the pathology and having a discussion about those, you can see where we can come to an agreement. So it's more about pathology and radiology working together. And I kind of mentioned like there is subspecialties of specializing in pathology and radiology, but there's also talks of, and I guess talks to use the term loosely, but thoughts have been put out there of potentially merging the fields all together as we start moving and getting better diagnostic tools with radiology, and our pathology gets better, and we're being better able to find things sooner using radiology. What does it ultimately mean? Instead of resecting full tumors, we're resecting biopsies and getting diagnosis. So using a combination of radiographic imaging and biopsies and making sure that our measurements are accurate, we can get a true diagnosis without fully opening the patient up for unnecessary surgery, if that's the case. Where this could be interesting is things like in the recent years, thyroid cancers have been on the rise, and the reason for that is we're actually being able to find smaller tumors more often, and so as a result we're diagnosing and potentially even resecting those, which is not always a good thing. So sometimes we have to be mindful of how much information we actually have, but utilizing those resources and combining them can ultimately give us what is the ultimate goal for both professions, is to improve patient care and patient outcome. And so there's a couple of articles you can read to just kind of talk about it. They're a little older, but it's kind of nice to see how they can integrate and how close they really are. And it's probably something most people don't think about until they actually start thinking about it. So looking at the benefits, if we use both radiology and pathology in conjunction with each other and trying to improve patient care, is an overall improvement in the patient care as well. And you'll find, as you'll get kind of beaten in your head at Rosalind Franklin, is interprofessionalism does work. And so having multidisciplinaries work together ultimately helps the patient. And show the other thing this can do is prevent a misdiagnosis. So a lot of times if you have different professions reading different reports, they might catch things that don't make sense, and so you actually have to defend those or get those clarified. The other thing this can ultimately do, and it hasn't gotten there yet, and we'll definitely talk about this in our lab operations lecture, but you can get standardization of clinical records. So usually radiology has their own system and pathology has their own system, and all the reports hopefully feed well into the electronic medical record, but they might not always communicate effectively. So having a standardized record is ultimately the goal, so that you can just have one system that gives you the information you need. And then eventually you can just use all this to help research and get better at these jobs and improve our results. And we'll look at examples of that, of how we can use radiology to help make diagnosis and clinical decisions. The first good example of that is the BI-RAD system, which is Breast Imaging Reporting and Data System. And you'll go into a little bit more detail of this. You don't have to know the specifics for this lecture, but when Mary gives her breast lecture, we'll talk about this as well. But this was developed in the 80s, and it basically uses the imaging techniques for breasts, which started off with mammograms, and now has evolved into things like ultrasound and MRIs. And it takes those findings, and after lots and lots of data has been collected, we can get an idea of the breast composition, and base that off of what we see in the findings and any sort of densities or masses that are identified. And we can start making clinical decisions based off the likelihood of those becoming lesions. Like I said, sometimes too much information is a bad thing, particularly when we think about those thyroid tumors. And if every tumor is a necessity for resection, sometimes a wait-and-see approach is much better. And so the Bio-Rad system is an important tool to that. And additionally, it's constantly updated. So once the tumor is resected, we can take what we found from the Bio-Rad and the decisions that were made and correlate them and see if we can improve the accuracy. Was it really a tumor that needed to be resected, or maybe not? And the data gets better, and we get better at making decisions. Additionally, there's a gentleman up in the Medical College of Wisconsin who's trying to correlate MRI images of the brain to accurately stage glioblastomas. So glioblastomas are a very malignant tumor of the brain and often result in death within the first year. But it might be, if caught at an earlier stage, an opportunity for treatment and something that can be fixed. So resections can be difficult in these cases because we have what's known as infiltrated borders, so you can't necessarily just resect only the tumor. But being able to look at the histological type through an MRI image and correlate pixel by pixel, if this is an early stage or a late stage, might allow the patient to live a little bit longer, which is valuable for some people for sure. So now let's take a look at the moment you all been waiting for, and that's how does all this relate to your role in surgical pathology? How often are you going to use radiology or medical imaging? What will you interact with on a regular basis? How safe is this? Are you going to develop a third leg? Hopefully I'll answer all those questions by the end of this unit. The main ways that we use imaging in surgical pathology is to formulate a plan, which is always good, and I kind of alluded to that earlier when we want to try to find our lesions. You're going to do quality assurance, which we just saw with the Bio-Rad stuff, is you can go and feed that data back into the system, and then ultimately there's safety. So we have to make sure that we're being safe and that we can indicate the safety of our patients and fellow workers. So when you start going into the lab, you're going to ultimately be looking at some radiology reports, so you'll have to get comfortable with how they're formatted. Now, they're going to look different depending on what place you go to, and every place has their own format. And I did mention earlier that ideally with radiology and pathology kind of working together, we can get one unified report, but that's not the case. And these reports are really just sort of a summary of findings. But we'll look at some of these in lab and get an idea of what to look for, but the goal is try to find the important information and utilize it for your clinical making decisions, or clinical decision making, I should say. So the type of exam done, so was it an x-ray or an ultrasound? The clinical history of the patient, is it a mass in the breast, a kidney stone? Compare it to the surrounding tissue, what is the technique used? So how much radiation was used? Did they do a full scan CT? Did they do it in the abdomen, or did they do it in the thorax? Was it sagittal, transverse, all that stuff? What are the actual findings, and what is the impression? What does that finding kind of indicate for you? Once you're comfortable looking over the reports and trying to pull out the most pertinent information, then you can start doing the quality assurance aspect. So let's look at an example here. IR reports, remember that's interventional radiology, that they place 2 clips near a breast mass. And what you'll learn is that when they do breast biopsies, they put these metallic clips in. They're very small, and you have to find them when you gross these specimens. But the IR report says they placed 2 near a breast mass. However, when you're grossing, you only found 1 clip. So what do? Well, that's something that you definitely have to document. So where did that clip go? You can't just say there's only 1 clip and then move on with your day. You have to indicate that this does not correlate with the imaging report. Let's take a look at another one. So, the previous imaging identifies 3 masses in the left lung. You gross the specimen and only find 1 prominent mass. So what does this mean? Are you blind and not able to see the 2 other masses? I don't think so. I think more likely the mass, or the 3 masses, might have converged and grew into a single mass. But again, this is something that you're going to want to report because that's important for quality assurance and helps give a better picture of what's going on in the patient, and it'll ultimately decide how treatment effects will or how treatment will play a role in the patient's care. So just like in clinical history, what you see when you're doing grossing is you want to make sure that anything that's in the radiograph findings are indicated or noted, especially if they are different than what you found. So sometimes, even just referring to the history in the radiographic findings, you'll state those in your gross description, or at least be included in the initial patient's pathology report. And then any sort of differences or discrepancies also have to be noted. So this is an important part of our job, is being able to make sure we have quality assurance for all departments, and there's other departments that'll do it for us as well. So in essence, we have quality assurance for surgery, pathologists have quality assurance for us, and then clinicians have quality assurance for the pathologist, and the circle of life continues. So now let's talk about safety in the surgical pathology. So there are indications where you might be exposed to radiation, and radiation is dangerous, but usually in a clinical setting we're not dealing with large doses of radiation, so you don't have to worry about this being a Chernobyl level event and you potentially succumbing to radiation sickness and poisoning. But safety is still important. So things that are going to cause potential exposure are specimen scanning, sentinel lymph nodes, prostate seeds, radioactive seeds and lumpectomies, explanted tissue, and radiation therapy, or status post is the SP. So specimen scanning, some labs, if you're fortunate enough, are going to have something like a Faxitron or a CubTech. And these are little portable X-ray machines that you stick specimens in and you can get a nice little image. They're really helpful for identifying those biopsy clips I mentioned earlier that they use for breast biopsies, if you can't find them. And they're also good for finding diagnostic features such as calcifications on tumors, or even identifying the mass. So sometimes places will have you place the specimen in there beforehand and you'll know exactly where you can focus your resection. Or if you're having difficulty finding the tumor, you can go ahead and place the sections in there afterwards and hopefully identify what you need. So when you have one of these in your lab, well, your lab's going to make you do a radiation exposure test. So you'll wear this little badge for a day, and you can basically determine that you're not overly exposed to radiation. Now these are perfectly safe even for pregnant women, but it's just making sure you're doing our due diligence, because you don't want to mess around when radiation comes into play. But things like Faxitrons are really nice, and ORs will usually have them because they want to confirm the removal of the tumor as well. So in a case of a lumpectomy, they'll put the specimen in a Faxitron right after surgery, make sure that the tumor and the clips are present, and then send it down. So usually that helps with the quality assurance, but that's something we can do too, is if we don't see those two clips on the Faxitron, then we can report it back up to surgery. And the nice thing about the Faxitron is it picks up metal really nicely. So even if that clip happens to just kind of be like tucked on the side where you couldn't see it, it'll be shown up quite clearly on the Faxitron. So sentinel lymph nodes, and I won't go into too much detail about this, is another potential exposure for radiation. Now, you don't have to know all the nuances of what a sentinel lymph node is and how it works. We'll cover that in more detail as we get into heme lectures and breast pathology. But basically what is the theory behind this, and I guess it's not really a theory because it pans out, is we're going to stick a radioactive solution, namely this technetium-99, into the patient's tumor site. And what will happen is lymphatics will take all that extra cellular fluid and absorb it. And so we'll be able to see which lymph nodes are the first ones to be drained by the area of the tumor. So this is really good in breast biopsies, and you also see this done for melanomas particularly. But they'll do it in the axillary region because you have a lot of lymph nodes and a lot of sort of cross-feeding lymphatics. So what you'll do is give it time to spread. They can go in with a Geiger counter and try to find which lymph nodes are actually hot and active with the radiation, the radioisotope. The blue dye could also be used to help you give a visualized effect to that. So sometimes you'll get these lymph nodes and they'll have this like blue look to them, and that's part of the dye. So this will help the surgeon know, okay, this is the first lymph node, and maybe they'll take another one, the next one afterwards, and this is the second lymph node. So this first lymph node is where the extracellular fluid drained first from the tumor site. So let's go ahead and take that lymph node. We'll send it down to surgical pathology and do a frozen section. If you can confirm that there's no tumor in that lymph node, it's a safe bet that no tumor made it past that lymph node either. So there should be no tumor cells in the rest of the lymphatics in that region. Now, if there's tumor in that lymph node, that means it's already spread to the lymphatics and maybe a more extensive surgery is required. So these specimens are considered hot because they do have radioactive material in them. Usually by the time you get them for frozen section, they're relatively safe. Again, the half-life of the technetium is pretty low, or pretty quick, I should say. But they will show up pretty hot on a Geiger counter, and you can use a lead shield, and we'll talk about some protection measures that you can take if you are worried about that. But that is a hot specimen, and we refer to that as being something that is radioactive. But this is a visualization of everything I just kind of mentioned. So you can see they're going to inject the tumor with this blue radioactive dye. We see, okay, these two lymph nodes are going to be some of our sentinel nodes. So the tumor, if any cells spread to the lymphatics, which is a common pathway for tumor spread, these are going to be the first two that would have been impacted. And so what we want to see is there tumor there? If not, these lymph nodes should be clear of tumor as well. If there is, well, now these tumors or these lymph nodes could have tumors, so we'll probably have to resect them all just to make sure. And then that's when you start doing lymph node counts and things like that. Another potential area for exposure is in this brachytherapy, which is commonly done for prostates, but you can also see this in other cancers. And what this is these little tiny radioactive pellets that you see down here are inserted into the tumor and basically give off this little radioactive field that's going to help obliterate the cancer cells surrounding it. So ideally, it's going to basically give you a radiation therapy constantly with the patient. So as you can imagine, they can't take these out, or it'd be a very difficult procedure to take these out over time. So they just use something with a very quick half-life, and after a few months they should be inert and non-radioactive. But sometimes you'll find them while grossing. So if they ended up having to go resect a prostate and the history says brachytherapy, then you should be looking for the seeds. Or sometimes you're in autopsy and you section the prostate and you cut into a seed. Now, if you do happen to puncture one, that's a concern for radiation safety. And even if you find these, you should contact your local radiation safety officer, because they are relatively contained, just like we'll see with the breast seeds as well, with the radiation material. So we want to make sure we don't open them and expose them. Although again, these are not levels of radiation that are going to cause you long-term harmful effects, and ultimately they just leave it up to pregnant women as being more of an opt-out sort of thing, just out of safety. But they should be for the most part safe. Lumpectomy seeds, so these are different than clips, and this is another potential exposure, very similar to brachytherapy, except this is in lieu of doing it for treatment, they're doing it for localization. So normally when a lumpectomy is about to be performed, the woman or man will go over to the clinic and try to get their biopsy done, make sure that the tumor length is confirmed. They'll usually put the biopsy clips, or if they've done a previous biopsy site, they'll verify that the clips are in place. And those will help kind of, normally in surgery, identify where the tumor is. But in order to see those tiny clips externally, they'll usually place these little biopsy wires. So you can see these, and this is referred to as wire localization. And so prior to surgery, the individual or the patient will have these wires sticking out of their bodies. Now this is ultimately fine if you proceed right to surgery, but sometimes you don't, and maybe you have to wait an hour and you just have these wires sticking out of your chest. Well, these radioactive seeds is a new technique that they're using, where they'll actually, instead of placing wires, they can put at least these little seeds, which you'll see here, very small seeds. And over here you can actually see that little T thing, that's the clip. So the seed to the clip, you can notice the seed is much bigger. So those clips, no joke, are really, really small, and they'll be initially the bane of your existence, but also the source of many joys when you either find one or cut into one with a knife on your first slice. So very nice. So what this does is, within a week period, so you don't have to necessarily set it up right away, you can place these seeds in, and then the surgeon can have a Geiger counter present and use that to verify the location of the tumor. So these don't have therapeutic value, not like we saw with the brachytherapy. These are strictly for localization and in identifying the tumor. So the surgeon can go in and say, oh, yep, there's the tumor right there. I'm going to make sure I only resect this region because I know the tumor should be about 2 centimeters, so I'll take a nice wide margins, and then we can confirm that in pathology using things like a Faxitron. So at the hospital I worked at, NKU, this was because we switched over to these localized seeds. This is why we sort of got the budget for Faxitron, so you can visualize, like, yep, seeds in place, and then it becomes a whole chain of custody thing where you have to make sure you document the seed was removed and then placed in a lead-based container and then taken away. And you don't want to lose these, and I can definitely attest to that from personal experience because it becomes a big, big deal. But overall, other than the regulation, this is the volume of radiation is minimal again, so there's nothing in here that's really going to cause any long-term damage or have a long-term environmental impact. But because we're dealing with radiation, safety is better than sorriness. So always maintaining the chain of custody and making sure you're protecting yourself, working behind a lead shield, letting specimens cool off if need be, and we'll talk about that in a little bit, but making sure that we're being as safe as practically possible. So I keep repeating the dangers of radiation and how it's important to take safety concerns. So let's talk about that, so hopefully you don't get too scared off, and then if a radioactive specimen comes down, you don't run away and hightail it out of the lab. So first, let's talk about how radiation actually hurts you. So non-ionizing radiation is mostly safe, and I say mostly because although the radiation is not enough to interact with your cells and cause any damage to your DNA or the cell structures, long-term exposure can cause burns, and a great example of this is UV lights, that also is a combination of ionizing and non-ionizing. But even you can see this in microwaves, for instance. When you put microwaves in, it doesn't actually cook your food per se. All it does is vibrate your molecules of water. But as you can attest to somebody who's gotten things like pizza pockets out of a microwave and eaten them too fast, or sorry, what is it? Pizza rolls, not pockets, but they can be quite hot, so there's definitely heat generated, and it can be very problematic for long exposure. So if you put something in too long in the microwave, you can definitely burn it and destroy it. So non-ionizing, typically non-reactive, but not immune to health concerns. But it's ionizing radiation, that's the one we want to concern ourselves with. That's the one that's going to cause significant damage. And so what that does is it can interrupt and destroy our genetic tissue. It can ultimately destroy our organs and make them non-functional. A common site for ionizing radiation to disrupt is our bone marrow. And so what we'll see is your bone marrow, if exposed to particularly long stints of radiation, will just become dead, and you'll no longer be able to produce enough hematocytes, and you'll basically become anemic. So that tends to be the area of most concern. But things like thyroid, if we get the radiation exposure, a lot of iodine radiation, or sorry, iodine isotopes become formed in radiation scenarios, and our thyroid tends to pick that up as well. So our thyroid is very prone to effects of ionizing radiation. But ultimately what's happening is we're either destroying the highly dividing cells like we see in bone marrow, or causing an uptake of radioactive material that's going to cause its own concerns. But it's that destruction of DNA. And so ultimately when we think about disease state, and this really applies to cancers, and you'll see this is kind of the process by which a lot of cancers develop, is any sort of cell division. When you cause an event that will increase the amount of cell division you'll have, that's going to ultimately lead to an increased potential or risk for mutation. So every time a cell divides, you're going to increase the likelihood that one of the nucleotide base pairs is going to delete, or you'll get one added, so you can potentially increase the risk of mutation. And when you get mutations, that's when you're in the realm of tumors. Now, not all mutations are going to lead to tumors. Some are silent. Some might lead to non-functioning aspects of the organ or tissue, and some might actually lead to an excessive growth. So we have what's known as tumor suppressor genes, and if those get sort of killed off, then the surrounding tissue or that cell type can keep growing and growing and growing. So anytime we do any sort of cell damage and start hitting our DNA and potentially interacting with it with this highly reactive radiation, that's ionizing radiation, that's when we are potentially at risk for things like cancer and other effects. Fortunately, it's really easy to protect yourself from radiation, and the way to do that is 3 principles. You can either use time, distance, or protection. Time is just walk away. Take time to let the specimen sort of do its thing if it's radioactive, and over time the half-lives are going to kick in and it's going to become less interactive. So additionally, the longer you're exposed to radiation, it has a cumulative effect. So that means if you're standing by something for a long period of time, that effect's going to continue to pronounce. But if you're only there for a brief moment, usually you can be a-okay. If you've seen the series Chernobyl on HBO, there's a scene where individuals are running on this really reactive rooftop, but they only have like 90 seconds, so the goal is be in and out. You're limiting your exposure and hopefully not getting this cumulative effect of radiation. So minimizing your exposure, just wait it out. Don't be around radioactive material for too long. A lot of times things in the clinical setting are just going to, after a day, be inert or non-reactive. Additionally, distance is a really good way to protect yourself. So like I said, walk away. If you got something that's radioactive or exceptionally hot and you're concerned about it, put it in an area of the lab that no one's going to be in. And radioactive material obeys the inverse square law. So if you remember that from physics, what that means is when you double your distance away, so if I take 2 feet away, it's the equivalent of basically taking 4 feet away. So, well, essentially quadrupling my distance. So if I looked at it as taking 1 foot to 2 foot, it'd be like 1 foot to 4 foot, if that makes sense. But just think, if you double your distance, it's the effect of quadrupling your distance away because of the way the inverse square law works. So this is a very good tool. So if you got something, wait it out, put it in the distal part of the lab that no one's going to interact with, and everyone should be safe because it loses its reactivity quite quickly upon stepping away. And then finally, you should have protective equipment in your lab. Any place that works with radiation will have this stuff. So you need protective barriers, protective apparels, you'll get lead shields, things like that. And we'll see some of these in lab that you can work with. And make sure if you don't have them, you contact your hospital's radiation safety officer so that you can get them. So when trying to keep track of how much exposure to radioactive material you've had, first off, always make sure that you know where your radiation safety officer is in your facility. Like I said with the Faxitron stuff, they'll be in contact to make sure that you have proper badges. You usually do these things once a year. If you have any sort of reactive equipment in the lab, they just want to make sure and test your levels so that they're constantly low and there's no danger. And they even have special badges for individuals who are pregnant that will test to see if the radiation is okay for a fetus to be around as well. So you can get things like Geiger counters and dosimeters and a lot of stuff that'll protect you while you're being or in an environment where we're working with radioactive material to make sure you don't go over the acceptable limit. So we measure radiation in a term called RAD, or radiation absorption dose. And so this is just a measure of the exact amount of radiation you have, and 1 rad is 0.01 joules per kilogram. Now, you don't have to exactly know what that is, but that's just something, if you hear the term rad, that's what that means. Now, a rad is, not all rads are created equal. So we've already looked at different scales of radiation, right? If you think about that chart we had at the beginning of the lecture. So things like gamma rays are really aggressive and really reactive, but things on the lower end, like some of those UV lights, are not. So we use a term called radiation effect in man, and I know it sounds a little sexist, but it is what it is. But it also means we can say REM, which is a cool band from the early 90s. So what this is the amount of biological damage received from the dose. So again, if you're getting hit with a little bit of UV rays that are a little bit ionizing, or even some of the non-ionizing rays, they're not going to have the same effect as something like a gamma ray. So in the cases of a gamma ray, or even X-rays, 1 rad is equal to 1 rem. So they're basically equivalent. So they do the same amount of damage, and it has a similar biological effect. But ultimately, a rem is going to measure the quality of that impact and whether or not it's concerning, whereas a rad is just an overall measurement of what's in the air or what you're being exposed to. So you kind of use both in conjunction. So if you're curious about how much you can take in a lifetime, there's actually a formula you use. So number of total lifetime permissible doses of rads is going to be 5 times whatever your age is minus 18, and that'll give you an idea of how much radiation exposure you should realistically have to a safe radiation exposure you can realistically have in a lifetime. And just to give you an idea what dosage you're really interacting with when you go to the hospital and get things like x-rays and scans like that, we're talking about millirads, which is 1,000th of a rad. So a chest x-ray is 10 millirads, where if you do it in the abdomen, it's 300 millirads, a little bit more, a little bit less protection because you don't have the bones there. And CT scans, really small amounts of 1 to 4 millirads per slice. So you've got to get a lot of x-rays in, a lot of radiographic imaging in to really hit some of those high dosages there. So for the most part, we're relatively safe with what we're doing with the clinical environment, and anything we interact with in a surgical pathology lab is going to be in that low millirad area. And again, the half-lives are usually so small that it's going to be a non-issue. But some people, it's definitely something to be concerned about, and like I said, better safety than sorry. Better safe than sorry, I guess is the real term. So that's pretty much it. But that's all I got for you for medical imaging. Let me know if you have any questions, and hopefully that was an informative little tool. And I will catch you next time. Thank you.